Well, it is 5 o'clock now, so I think we'll start because we have a lot to cover today. We're absolutely delighted to have Dr. Richard Horowitz with us. He's not in Amsterdam, I believe he is still in New York, but he is, first of all, to introduce him, a board-certified internist in private practice in Hyde Park, New York. He's medical director of the Hudson Valley Healing Arts Center, an integrative medical center which combines both classical and complementary approaches in the treatment of Lyme disease and other tick-borne disorders. He's also worked in the HHS services for the US government for several years. That's the Health and Human Services, and he has been one of the initial members of the tick-borne working group that actually gave recommendations to the US Congress on tick-borne disease in 2018. That was recommendations on diagnosis, prevention, and treatment. He has treated over 13,000 patients with chronic Lyme disease in the last 30 years, with patients coming from all over the US, Canada, and Europe to his clinic. Over the last several months, he's written 2 articles in the medical literature on COVID. The last one actually just appeared yesterday, and he's been updating his presentation on COVID almost every day and has just updated it again today for us here in the UK. We feel very privileged, and actually because he has so much to tell us about novel diagnosis and treatment options, he will be speaking for a bit longer today, probably 90 minutes. And after that, we'll have about 20 minutes of questions. So it will be recorded and up on our website. So if that's a bit longer than you can manage today, please don't worry. But we are just very excited to get as much as we can, basically, from you, Dr. Horowitz. So thank you.
Oh, it's my pleasure. So let me welcome everyone. I hope you guys are doing okay, considering how bad the pandemic is. And I've certainly been following the European numbers, and it looks like the UK is not doing too badly right now from the last numbers that I saw. But of course, in other countries, Russia, Iran, and certain other parts of the world, it's getting much worse. So let me just share my screen here with you.
Thank you. By the way, everyone, if you'd like to put your questions into the Q&A box, which you can see there with your cursor at the bottom of the screen, we'll ask as many as we can at the end and collect others that he hasn't been able to answer. And he's kindly said he'll be very willing to come back again in the future. So hopefully we can cover them all at another point if we don't today. Thank you.
Okay, great. So let me start. So what I'm going to do for you today is give you a very comprehensive overview of COVID-19 regarding prevention, diagnosis, and treatment options. And thank you again to the sponsors to allow me to do this for you today, because I'm really excited to share the information that I have on COVID. We've now treated patients in our practice very effectively, actually, with the protocols I'm about to discuss. And not one of them has ended up in the hospital in an intensive care unit on a respirator. So whether we're lucky or whether these protocols work better will determine over time with randomized trials. I do have conflicts of interest and disclaimers. I have 2 books, Why Can't I Get Better and How Can I Get Better, from St. Martin's Press. I'm on the Zymogen Board of Advisors. I've received grants from the Bay Area Lyme and the MSIDS Research Foundation. And most importantly, the views expressed in this presentation today do not represent the views of the Tick-Borne Disease Working Group, HHS, or the United States. So starting with coronaviruses with an overview, they were first characterized in the 1960s. They're a large family of envelope-positive strand RNA viruses with spike glycoproteins that cause a substantial proportion of upper respiratory infections in children and adults. And there are 7 coronaviruses that are known to cause human disease, either of low or highly pathogenic potential. The 3 most highly pathogenic coronaviruses that I think most people know about is the SARS coronavirus, now named SARS-CoV-1, the Middle East Respiratory Syndrome, or MERS coronavirus, and SARS coronavirus 2, which is the agent of COVID-19, which was the one initially identified in the patients in Wuhan, China, with severe pneumonia. Regarding viral shedding and intubation, we know that the median incubation period is 4 to 5 days. After becoming infected, 97% of people will have symptoms within 10 to 11 days. And viral shedding can happen up to 3 days before becoming symptomatic, and 40 to 50% of the cases are likely transmitted from asymptomatic individuals. And the WHO had recently pulled back one of their statements that the transmission from asymptomatic individuals was not highly likely. We know that it is. This is a very important slide because one of the early prodromal symptoms to know whether you may have been exposed is anosmia, hyposmia, and dysgeusia, meaning you lose your sense of smell, your sense of taste, or it just may be diminished. And it's usually followed days later by fever, chills, cough, shortness of breath, fatigue, gastrointestinal symptoms, including nausea, vomiting, and diarrhea, and occasionally a sore throat, headache, muscle pains, and rarely conjunctivitis, and even a cough with hemoptysis with blood in the phlegm has been reported. But the reason the anosmia, hyposmia, and dysgeusia is so important is these are early prodromal symptoms that you should be isolating and not being out in public because it means you've been exposed to the virus. There are very few diseases that cause a sudden loss or decreased sense of smell and or taste. Usually in the medical literature, it's been associated with trauma, rhinosinusitis, nasal polyps, and viral infections. 5% of people can have functional anosmia as they get older, where they lose their sense of smell. 25% of people over 50 years old have impaired smell. And normally in medicine, we usually associate this with early neurodegenerative diseases like Alzheimer's disease, Parkinson's disease, Lewy body dementia, because in Alzheimer's, people will lose their sense of smell early on, and we know that that's an early symptom that someone may have been going on to get Alzheimer's later on. Recently, they've discovered there are 5 categories of dermatological manifestations of COVID. Among these, pseudo-chilblain, looking like you had frostbite, it's almost 20%. Vesicular eruptions, 9%. Urticarial lesions, almost 20%, so it looks like hives. And then maculopapular lesions, 47%, and livedo or necrosis, 6%. So the pseudo-chilblain lesions, what they call COVID toes, are usually been affecting the younger patients, and it's actually, in a sense, a good sign because it's associated with less severe disease. And this, by the way, this comes from the British Journal of Dermatology. The vesicular lesions are affecting middle age and intermediate severity. But if you were to get urticarial lesions, maculopapular or livedo, necrotic lesions, these are associated with more severe disease. And occasionally herpes zoster has also been seen. But again, this is not common, but it has been seen with reactivation of herpes viruses. So these are some of the pictures of the younger people who've ended up with COVID toes. As we said, it's an early symptom that you will generally see in the younger population and associated with less severe symptoms. One of the early prodromal symptoms that people have to watch for is central nervous system symptoms, confusion, acute necrotizing encephalopathy, and stroke. So altered brain function can be an early sign. Now, again, if you look at these symptoms of headaches, confusion, seizures, tingling, and numbness, we do see this with tick-borne disorders. You can see it with Lyme disease. You can see new onset of seizure disorders with Bartonella. You could also see it with tick-borne encephalitis virus in Europe or with Powassan encephalitis here in the United States. But the worst complication that we're now seeing is what's called acute necrotizing encephalopathy. And this can be sometimes associated with large vessel stroke in the young. And we know that this is one of the associated symptoms with this inflammatory response that's happening throughout the body. So neuroinflammation has now been seen in COVID. Initially, they were not finding DNA or PCR positivities on a lumbar puncture, but now they know that there is blood-brain barrier dysfunction, and occasionally they are finding the virus in the central nervous system. What's also interesting is that this disease has been associated in some cases with Guillain-Barré syndrome, Miller-Fisher syndrome, polyneuritis cranialis, and epilepsy, as well as stroke. So again, keeping in mind with COVID that any unusual neurotropic presentation, including Guillain-Barré, which has been associated with the flu and sometimes with vaccines, can also sometimes happen. You need to think about COVID in the setting of what's now happening neurologically with the pandemic. Other neurological complications, as we said, could be not only Guillain-Barré, but even multiple sclerosis type symptoms or acute disseminated encephalomyelitis. So post-infectious, immune-mediated complications in the convalescent period are possible. As we said, they are now finding viral RNA within the brain tissue and the central nervous system. And meningitis and encephalitis with acute flaccid paralysis can be associated with COVID-19. Now, I don't think this is extremely common, but again, it needs to be kept in mind for any people who are experiencing any unusual neurological symptoms. And autoimmune inflammatory and demyelinating symptoms can be seen in susceptible individuals. And these susceptible individuals could, of course, be those who have tick-borne disorders like Lyme, who do get demyelination, or people who have MS. One of the most severe complications that I know you're all aware of is novel coronavirus pneumonia with or without acute respiratory distress syndrome, or ARDS, with respiratory failure. And we also are seeing organ dysfunction damage with cardiac injury and fulminant myocarditis. So you're getting inflammation in the heart. Rarely people are seeing pneumothorax. Liver function, again, is a sign of inflammation, and acute kidney injury. The cardiac complications, they're now calling acute COVID-19 cardiovascular syndrome. It's due to this cytokine storm that we're about to discuss, where there's a tremendous amount of inflammatory cytokines, TNF-alpha, IL-1, IL-6. Many of these cytokines start coming out, and that is inflaming the heart with a myocarditis. It can cause microvascular injury and even a stress-related cardiomyopathy. So you could have someone with an underlying cardiovascular problem who could get congestive heart failure from COVID or cardiac arrhythmias. What they've now shown is that you can get increased troponin looking like you have cardiac damage with an early heart attack. But if these patients are cardiovascularly stable, they don't need extensive cardiac imaging. You would simply follow the troponin levels, you would follow the EKGs, but they do not need extensive imaging. 1/3 of patients are now showing up with liver abnormalities, with high AST, high ALT, occasionally alk-phos and total bili. And we've seen now that there's a higher percentage of these liver abnormalities on these people who've taken lopinavir and ritonavir, which are some of these antivirals that are now being used in COVID-19. Acute kidney injury is also seen in patients hospitalized with COVID-19, again from the cytokine storm. And it's all 3 stages of kidney injury: stage 1, stage 2, and stage 3. And as you can see, there are independent risk factors for kidney injury, which we're about to discuss, which is older age, over 60 years old, if you are African American Black, if you have hypertension, diabetes, including elevated hemoglobin A1C, underlying cardiovascular disease, vasopressor use, and of course, need for ventilation. Now, of course, the question that everyone is asking at this point is how many people will actually get sick from COVID? And of course, we need to look at the risk factors. The number of people who will die is a function of how many people there are, how the virus is spreading, and how many people the virus is capable of killing. But then you start to fill in the blanks, and of course, there are a lot of questions because we don't yet have enough testing in the worldwide population, and we still don't really know the true numbers of how many people are getting sick and dying. The risk factors, as we said, is older age, being male, as I show you, low testosterone, race, obesity, not surprising with obesity because metabolic syndrome with elevated body fat will increase IL-6 and some of these inflammatory cytokines, smoking history, and hypertension, diabetes, cardiovascular, and respiratory diseases, as well as those people who've had hemorrhagic or ischemic strokes, who are immunosuppressed with cancer, chronic kidney and liver disease, as well as secondary infections. There's, of course, been a lot of talk in the literature because the virus enters through the ACE2 receptors to get into your cells. Is there a risk of using ACE inhibitors or angiotensin receptor blockers? And what the American Cardiology and others have now said is that no, there is no increased risk. You should not be stopping ACE inhibitors or ARBs in patients who have hypertension, who have congestive heart failure. This was recently published that an elevated hemoglobin A1C increases your risk of inflammation, as well as hypercoagulability. We're going to talk in a second. I think most of you probably know that in the beginning, we were seeing high D dimers, and they were not sure of the significance, but they now know that blood clots and pulmonary emboli and large vessel strokes are now associated with COVID from inflammation in the blood vessels, and this has a poorer prognosis. There are 2 studies now that have looked at low testosterone as being a risk factor in older men, and I will show you in one of the studies that I recently published in the medical journals, one of my patients, who was a Lyme patient who had active symptoms, did have low testosterone, but of course he had a very good outcome, as I'll show you, from using glutathione, which is one of the things, and really quite exciting, as I'm about to share with you, in these patients who've had COVID pneumonia. So in one of the studies, in a German study and another Spanish study, they showed between 68% and 79% of men in Germany and Spain admitted to the hospitals had low testosterone, and they think that this may increase your risk because it deals with an inflammatory response to the pathogen. They're also now starting to show genetic risks. That type A blood might increase your risk, and type O blood would be a lower risk according to 23andMe. And now they're showing that there are loci on chromosome 3, the CCL2 SNP, that may also be associated with an increased risk of COVID-19. Initially, we thought that children were not going to be at great risk, but we now know that there's something called multisystemic inflammatory syndrome, or MIS, and these children are getting what looks like Kawasaki disease with an inflammation in the blood vessels, and they may get toxic shock. In pregnant women, they've now shown that the placenta can occasionally be affected. There was a small study that was done on 16 pregnant women that found some evidence of injury to the placenta, where insufficient blood flow from the mother to the fetus occurred because of blood clots. And fortunately, the babies were healthy. But if you're pregnant with COVID-19, this therefore says we need to maybe think about testing oxygen delivery of the placenta during pregnancy and following intrauterine growth spurts via ultrasounds. And that's something you should be discussing with your OB/GYN if someone is pregnant and does get exposed. Interesting that the risk is lower at high altitudes. This is from the Andes to Tibet. They've been finding lower numbers. They might have thought that this is a combination of our ability to cope with hypoxia, low oxygen tension, and natural environments hostile to the virus, like dry mountain air, high levels of UV radiation, and that lower barometric pressures reduces the virus's ability to linger. But what's quite interesting is when you're at a high altitude and you get acclimatized to oxidative stress, your glutathione levels will go up. And as I'm about to show you, this is a very important point of this presentation. One of the key factors that looks like it may be causing some of the symptoms with COVID is as you get older and as you have viral and bacterial pneumonia and you have ARDS, it's all been associated with low glutathione. So people who live at high altitudes, the glutathione levels go up. They've shown that after 13 months at high altitude, their plasma total antioxidant status improved by 21%, and glutathione levels increased by 32%. So it may not just be the dry mountain air and UV, but it may also be because people have higher glutathione levels and can deal with oxidative stress better. Risk is increased with air pollution. The first study that just came out of Harvard showed that if you are exposed to these small particle pollutants, less than 2.5 parts per million, it increases your death rates by approximately 8% for every increase in these parts per million. What is the common denominator? Well, it is inflammation. We now know that environmental toxins and exposure to chronic diseases and infections, whether it's viruses or inflammation, can drive an inflammatory response. I published this several months ago on the 3 I's: infection, immune dysfunction, and inflammation. In the study, I was talking about infections such as Lyme disease and tick-borne infections, but it also applies to viral infections, which can cause immune dysfunction and inflammatory response. When combined with environmental toxins, will also drive autoimmune responses and free radical oxidative stress, which is part of the problem of what's now happening with COVID-19. So let's look at the risk by the numbers. In April 2020, as of April 11th, 1.7 million people worldwide had been infected. The global mortality rates, according to the WHO, were converging around 5.7%. It ranged at 14 to 15% in Italy and Spain, and very low numbers in certain other countries. In the US, based on death certificates and deaths attributed to pneumonia, influenza, or COVID-19, initially, when it came out in the United States, it looked like our death rates were actually higher, especially because a lot of those people early on in the nursing homes were attributing those death rates being on respirators. By May 2nd, over a month later, more than 5 million people had now been infected with COVID-19, which was 1 million new cases in the past 2 weeks. And new cases were emerging in Northeast China, where they had to shut down Wuhan again, Iran, and US states that loosened restrictions. And we just hit 100 to 110,000 cases in the United States. And we saw just 2 days ago for the WHO, we're now at about 7 million cases worldwide, 400,000 deaths as of June 9th. And if we look at the different countries, and this is just this morning, it was published in the New York Times, you can see that we've hit 2 million cases in the United States, where the curves are starting to flatten out. You can see the UK is on the right-hand side, that you've got about 290,000 cases, and your curve is coming down, which is very good news for the UK. But again, it's going to depend on when you start opening up more, whether you're going to see a spike in cases. And what I'm about to show you today, and I'm fairly certain about what I'm sharing with you, that if you look at the nutritional supplements I will be discussing with you today, N-acetylcysteine, alpha-lipoic acid, glutathione, which block NF-kappa B and lower inflammation. And I will show you that NAC and glutathione have antiviral effects by bonding with disulfide bonds to either the ACE2 receptors of the virus, either slowing or stopping the viral entry into the cell, and then slowing down the viral machinery by shutting down oxidative stress. We may be able to open up much more safely, but we do need a randomized controlled trial. So let's put the risk of COVID-19 in perspective. A useful way to understand the risk is by comparing the risk with what we call a micromort. This is a 1 in a million chance of dying, and the average risk per day before COVID would have been 1 micromort. If you got general anesthesia in the United States, that was 5 micromorts. What I find interesting, if you went skydiving, that's 7 micromorts. So you could turn to your wife or your beloved and say, honey, I'm going to go skydiving because you just went for general anesthesia and the risk is not that much higher. If you happen to drive a motorcycle at least 44 miles a day, that's 11 micromorts. That is higher, by the way, than skydiving. And giving birth, at least in the United States, is 210 micromorts, 30 times more than skydiving. So for every woman who's ever given birth, you have my congratulations, because you have put your life at risk, obviously, for having your children. And I think we need to honor mothers during this time. Any individual living in New York City has experienced roughly 50 additional micromorts because of COVID. And if you're infected with the virus, what they showed is your odds of dying jump dramatically. If it's a 1% case fatality rates, that is 10,000 micromorts. So we have to find a way to lower the risk, and that is these studies and the publications I'm about to show you today. It's very important to establish a clinical risk score. This came out about a month ago in JAMA Internal Medicine. They found, apart from age and your chest x-ray and dyspnea, shortness of breath, hemoptysis, blood in the phlegm, being unconscious, comorbidities, that LDH, lactic dehydrogenase, and your neutrophil lymphocyte ratio, getting low lymphocytes, lymphopenia, was very, very important. The next study then came out in Nature, Machine Intelligence. They found that LDH, lymphocyte counts, and high sensitivity CRP were some of the 3 most important markers that you should be tracking for people before and during they get COVID-19. If you look at establishing a clinical risk score, you can see that if you have an LDH below 365, a high sensitivity CRP below 41.2, you have a much better chance of survival. But if those numbers are higher and your lymphocyte count is below 14.7%, this gives you a much higher mortality rate leading to death. So these are 3 markers that are very important, apart from, as I'm about to show you, ferritin and D-dimers, as well as looking at cytokines. So lymphocytopenia, these low lymphocyte counts and low natural killer cells are very, very important. Looking at low CD4, CD8 counts, these can also be indicators of severe disease. They recently published this, it was about 10 days ago. I'm sorry, it's last month, an Apache 2 score. I mean, you're in an ICU and they have scores to look at your physiology and your risk of dying. They found an Apache 2 score more than 17 would predict death. So how are we going to lower the morbidity and mortality rates? So this article is in pre-press. It's about to come out. It's about 5 support targets for COVID-19. What do we need to do as far as antioxidants, foundation support, anti-inflammatory support, looking at natural killer cells and Th1, which is what you need to be able to deal with the viruses. So this study just got published yesterday. It just went online in Medical Hypothesis, 3 novel prevention, diagnostic, and treatment options for COVID-19, which urgently require controlled randomized trials. And let me discuss with you in this article what we are seeing with COVID-19 that is not being actively discussed, which I think is quite important. Everyone, I think, at this point has heard of the cytokine storm, and that ARDS, acute respiratory distress syndrome, is the primary cause of death, with fulminant myocarditis and multi-organ function, as we discussed with kidney and liver and other organs. So this is an uncontrolled systemic inflammatory response, very large amounts of these pro-inflammatory cytokines, interferon alpha and gamma, interleukin-1 beta, IL-6, IL-12, interleukin-18, IL-33, TNF alpha, TGF beta. And then, of course, we've got chemokines that pull your lymphocytes and white cells to the site of infection. These are CXCL9 and CXCL10. These are, by the way, the same cytokines and same cytokines you get with Lyme. And where I'm going with this, and I'll show you why this is so important, is because I've been dealing with inflammation and Herxheimer reactions for 30 years in 13,000 Lyme patients. And because we knew in advance how to deal with inflammation in Lyme disease, it was logical to try the same approach for those with COVID-19. So the pathogenicity of COVID-19, and this is not being discussed actively, and this slide is very important. There is something called secondary hemophagocytic lymphohistiocytosis, SHLH, also known, and this is easier to say, macrophage activation syndrome, or MAS. For ease sake, we're going to call it macrophage activation syndrome. This is a hyperinflammatory syndrome characterized by a fulminant and fatal hypercytokinemia. So massive amounts of cytokines come out with multi-organ failure. And this has been published, by the way, in Viral Infections and Autoimmune Disease way before COVID ever emerged. So it's seen in approximately 4% of cases triggered by viruses like dengue fever and dorsepsis. What are the cardinal features of macrophage activation syndrome? And look at these symptoms and you'll see it's exactly what we're seeing in bad cases of COVID. Unremitting fevers, low count cytopenias, lower absent natural killer cells, and these are the cells you need to be able to fight your viruses, hepatosplenomegaly, right, increased sizes of the spleen and the liver, hepatobiliary dysfunction, coagulopathy, right, so these are the people with the D-dimers and clots, high ferritin levels more than 500, fasting triglycerides more than 265, and fibrinogen levels less than 150. Pulmonary involvement with ARDS can occur in up to 50% of patients who have macrophage activation syndromes. And as I said, these are all the fatal complications we're seeing with COVID-19. So let's talk a little bit about macrophage activation syndrome and how we're going to lower the inflammatory cytokine release from the macrophages. So as I said, it's been reported previously in autoimmune disorders and viral infections. The pathogenesis is macrophages and natural killer cells increase interleukin-1 beta, which causes this cytokine storm of IL-6, IL-18, ferritin, and interferon gamma. And high ferritin levels are the diagnostic hallmark of macrophage activation syndrome. So if you get a high ferritin level early on in someone, that is a diagnostic marker that someone is going to have a cytokine storm and is an increased risk of morbidity and mortality. But it needs to be done within the first 24 hours to be an accurate diagnostic biomarker for macrophage activation syndrome. And also, IL-18 can promote human macrophage activation syndrome. When we look at the pulmonary involvement in MAS, dyspnea and cough were the most common symptoms. Chest X-ray would show interstitial infiltrates with central lobular nodules, ill-defined consolidation, and what they call ground glass opacities, or GGO, and crazy patterns, crazy paving patterns. Now, these are exactly the same things that are found on chest X-rays and CT scans with COVID, previously described again with MAS. And again, you can see on the left, this is chest CAT scans. So this is COVID pneumonia on transaxial images. To the left in A is the ground glass appearance. B is the crazy paving pattern, or GGO, with superimposed intralobular septal thickening. And C is consolidation. You can see those early pneumonias. Now, some of these people go on to develop acute respiratory distress syndrome. In fact, 81% of critically ill COVID patients develop life-threatening ARDS, hypoxemic respiratory failure going on ventilators, and/or they get hypotension needing vasopressor treatment. So ARDS is caused by lung inflammation where there's increased alveolar, endothelial, and epithelial permeability. It leads to a non-cardiogenic, protein-rich pulmonary edema with severe low oxygen levels, hypoxemia, and decreased ability to excrete carbon dioxide. The etiology of this ARDS lung injury is these neutrophils and platelets are activated by oxidative stress, right? And they damage the endothelial and epithelial barriers of the lung, usually caused by pneumonia. When these neutrophils become activated, just as the natural killer cells and macrophages can do, they release these toxic mediators, including reactive oxygen species, these pro-inflammatory cytokines, and procoagulant molecules. And there's a synergistic interaction with the platelets, increasing damage. So this procoagulant effect with coagulopathy and antiphospholipid antibodies has now been reported in patients with COVID-19. And these abnormal coagulation parameters, high PT, PTT, high D-dimers, these are now associated with poor prognosis in patients with novel coronavirus pneumonia. So what can we do to decrease the risk of dying on a ventilator, right? And I know a lot of the doctors who are in the ICUs trying to help patients, they're very, very worried because up until now, there is no well-controlled trial saying, how can we help people on vents? Well, there was a group here that was discussing in the United States trying to control inflammation using steroids, which, by the way, you should not normally use with COVID. It's never been shown to decrease the mortality rates and can be problematic. IV vitamin C, which has been shown in certain Chinese studies and otherwise that it does seem to have some benefit because it has antiviral effects and helps lungs with antioxidant protection. And heparin, right? And this is early on before we knew about all the pulmonary emboli that are showing up in like 58% of the people who have COVID with these high D-dimers. So now the studies are starting to show, this is from the American College of Cardiology, that if you anticoagulate some of these people, you'll get lower mortality rates. Now, when we initially put our study in the medical literature, in medical hypothesis, we were talking about the D-dimers looking like it probably was pulmonary embolus, and in fact, it has now been proven. So in this study that they did in almost 3,000 patients who were hospitalized, and 28% received anticoagulation, those who received anticoagulation were usually those who were on mechanical ventilators, and they had higher levels of PT, PTT, LDH, high sensitivity CRP, ferritin D-dimers. And these are the risk factors that we talked about earlier. There are some of those key numbers that you have to look at because the higher those numbers, the higher the risk of dying from COVID. So if you gave anticoagulation, your risk of dying was 29%. And if you didn't give anticoagulation, it was 62%. So people did much better with anticoagulation when they had some of these high PT, D-dimers, LDH, CRP, ferritin, and a longer duration of anticoagulation was associated with a reduced risk of mortality. One other study looked at calcium channel blockers, that they may decrease the mortality rate for people on ventilators, but it was a very small study. We can't really say much about it. They've also looked at not putting people on ventilators and doing what's called non-invasive ventilation, and having people do kind of the prone position, increasing oxygenation in other ways with COVID-19. And they found that this non-invasive oxygenation did lower mortality. So you want to try and avoid getting on a vent and doing NIV, non-invasive ventilation with oxygen to try and prevent some of the complications. Now, if you do happen to have acute respiratory distress, you need to be careful with fluid balance, transfusions, neuromuscular blocking agents. They usually give people inhaled bronchodilators, which, by the way, don't work very well. And I'm going to show you a very interesting study on glutathione being an endogenous bronchodilator by combining with nitric oxide. Vasoconstrictors and anti-inflammatory agents, including steroids, have never been shown to have any benefit and may cause harm. Some may confer short-term improvement, but there's no long-term proven effect on survival. And it's primarily because this reactive oxygen species are overwhelming your endogenous antioxidants, resulting in oxidative cell damage. So what are we going to do to address these reactive oxygen species and inflammation? We're going to work on two separate pathways, and these are published in the two studies that I talked about in the literature, the one in Medical Hypothesis, 3 novel prevention, diagnostic, and treatment options, and in the study I'm about to show you on glutathione helping in people with COVID pneumonia. So the first is, if you activate what's called NF-kappa B, which is a switch inside the nucleus of your cells, activation of NF-kappa B is required for transcription of genes that turn on these pro-inflammatory mediators that have been associated with ARDS. NF-kappa B plays a key role in the orchestration of this multifaceted inflammatory response in both the pro-inflammatory phase and later in the resolution of inflammation when antioxidant anti-inflammatory genes are expressed, which are called the ARE genes. And these are, by the way, expressed through what is called NRF2 activation. So we want to block NF-kappa B through antioxidants. What are the 3 antioxidants that help block NF-kappa B? Well, they happen to be the same ones that increase glutathione in the body: N-acetylcysteine, alpha-lipoic acid, which allows you to regenerate glutathione, and glutathione itself. These have all been published to inhibit activation of NF-kappa B. So what am I taking and what I give to all my patients? And we'll talk about this at the end. 600 milligrams of N-acetylcysteine twice a day, higher, 1,200 twice a day if you get COVID. That helps your body to make its own endogenous glutathione. And it also has, as I said, properties which are antiviral. Alpha-lipoic acid, it could be anywhere from 600 to 1,200 a day. You just have to be careful with higher doses with reactive hypoglycemia. And glutathione, normally 250 milligrams twice a day. Higher if you're older, maybe 1,000 milligrams a day. But if you get COVID, we are going up to 2,000 milligrams of glutathione anywhere between 2 to 3 times a day. And I'll show you the study that we published on this. But all of these inhibit activation of NF-kappa B, helping to keep down the cytokine storm, which is ultimately the underlying reason why people are dying. We're not dying from the virus. We are dying from the inflammatory response from the virus, which is causing the coagulopathy and the strokes and the myocarditis and the multi-organ dysfunction. NAC and alpha-lipoic acid both upregulate and regenerate glutathione. So why N-acetylcysteine? Well, one of the other effects of N-acetylcysteine is what's called disulfide breaking activity. And when the virus attaches to the ACE2 receptors in the cell, it does so using disulfide bonds. So if you give glutathione and you give NAC, right, what you're doing is, number one, you're giving an antioxidant, and glutathione has anti-inflammatory activity. It can neutralize these potentially dangerous reactive oxygen species or nitrogen species, and it also helps with xenobiotics and metal to detox them from the body. It regulates cell processes. It also regulates the immune response, including the natural killer cell and T cells, which I'm going to show you in just a bit. So we need our natural killer cells and T cells to fight the viruses, and glutathione will support natural killer cells and T cells to do their work. So the concentration of glutathione and its oxidized form, glutathione disulfate, determines the redox state of the cell. And viruses alter the intracellular redox state to a pro-oxidant condition, and that contributes to viral pathogenesis. So if you can shut down that oxidative stress inside the cell, difficult for the virus to turn on the machinery to replicate. So one of the other roles of glutathione that is not very well known is called glutathionylation, and this directly has an effect in infection and inflammation. So what is glutathionylation? Well, it's an antiviral activity of glutathione and also NAC. Glutathionylation is the formation of mixed disulfides between protein cysteines and glutathione cysteines, because glutathione is a tripeptide. It has cysteine, glycine, and glutamic acid as the three molecules that make up glutathione, right? So if you're drinking whey proteins, you can also get cysteine that way to naturally upregulate glutathione production. Microbial proteins undergo glutathionylation with modifications of their functions. And as I said, viruses will alter the intracellular redox state to pro-oxidant condition, which is an alteration that contributes to viral pathogenesis, right? So this is one of the ways that we're looking at an antiviral strategy, is by looking at redox signaling inside the cell. Other beneficial antioxidants that we're using in our patients is called NRF2 stimulation and vitamin C. So apart from blocking NF-kappa B with NAC, alpha-lipoic acid, and glutathione, there's another pathway in the body that when you get free radical oxidative stress, there is a molecule inside your cells called NRF2. NRF2 is normally bound to keep one inside the cytoplasm of your cell. When oxidative stress hits the outside of your cell, causing lipid peroxides, NRF2 stops the binding to keep one, it goes inside the nucleus, and it binds to these antioxidant response elegant genes to lower inflammation and to increase detoxification. So what are the 4 nutraceuticals that do that? Curcumin or turmeric, sulforaphane glucosinolate, which is broccoli seed extract, resveratrol, which comes from red wine, and green tea extract, EGCG. So these are the 4 nutraceuticals that stimulate NRF2 to lower inflammation through a separate pathway than blocking NRF2. And these will block the macrophage inflammatory response. And as we said earlier, macrophage activation syndrome was what's happening in a lot of these people who get COVID-19 with severe morbidity and mortality. We also use vitamin C because it's been shown to decrease the duration of mechanical ventilation in critically ill patients. Other potential therapies that we're looking at is zinc. Zinc plays a key role in the immune system. It mediates nonspecific immunity. It can affect the neutrophils and natural killer cells. And zinc deficiency will increase susceptibility to pathogens. And what they found is after zinc supplementation, it decreases the incidence of infections, and it also decreases tumor necrosis alpha and oxidative stress markers. And that's exactly, of course, what we're looking to do in COVID-19. Other advantages of zinc is it inhibits induction of tumor necrosis factor alpha and interleukin-1 beta messenger RNA in mononuclear cells. Zinc provides protection against TNF-alpha-induced nuclear factor kappa B activation. And macrophages are adversely affected by zinc deficiency, which can dysregulate intracellular killing and cytokine production. And as I'll show you in a little bit, with all the controversies on hydroxychloroquine and Zithromax, it works, it doesn't work, it works, it doesn't work. Oh, let's pull the study in the Lancet. When they gave zinc to the people with Plaquenil and Zithromax, it seemed to work better. And I'll show you this study, and no one's really talking about it too much. The second study that we published in the literature was efficacy of glutathione therapy in relieving dyspnea, shortness of breath, associated with COVID-19 pneumonia. This is a report of 2 cases that we published in the Journal of Respiratory Medicine Case Reports, and we published it back in April of this year. So why were we interested in low glutathione? Well, they know that the elderly in the nursing homes are some of these people that have the highest risk. Well, there are two things you should know about the elderly. They have low blood glutathione, and they also have low melatonin. And as I'm about to show you in a bit, melatonin is necessary for dealing with what are called inflammasomes, which is also another pathway to deal with inflammation in the body. Now, this was published in 1992, where they showed that in older subjects, 60 to 79 years old, they had low blood glutathione compared to younger patients, significantly lower than the reference group. So it could be that one of the reasons that people are at higher risk as they get older is low glutathione, one of the primary antioxidants, which blocks NF-kappa B and helps your lung tissue to deal with the oxidative stress. Now, I'm not the only person who believes that glutathione deficiency is possibly the #1 important deficiency in people with COVID-19, apart from, as we'll talk about, vitamin D deficiency, K2 deficiency, zinc deficiency. There are many of them, but it is possible that glutathione deficiency is actually of primary importance. So let me explain to you these cases and show you what happened in these people who had COVID pneumonia. Both of these patients had a history of Lyme disease and co-infections. One of them had Anaplasma babesia. The other was Bartonella and Rocky Mountain spotted fever. They both presented with symptoms and signs of COVID pneumonia with shortness of breath. The first patient had a lot of autoimmune markers and inflammatory markers like anti-nuclear antibodies, rheumatoid factors, anti-cardiolipin antibodies. This person had high mercury levels in the blood because he was eating a lot of fish. He had low testosterone, which, as we talked about, was a risk factor. He had low normal cortisol, not great for dealing with an acute infection. But he initially had normal high sensitivity CRP and ferritin levels, and this is before getting sick with COVID-19. Patient 2, however, had improved from treatment after treatment for Lyme and Bartonella. They both had shared symptoms of loss of sense of smell and taste, anosmia, dysgeusia. They had severe fatigue, myalgias, muscle aches, chills, night sweats, which could also, by the way, be babesia, right? Headaches, sore, scratchy throat, shortness of breath with a cough, chest tightness, nausea and diarrhea. We've seen diarrhea in many of our patients. Dizziness and brain fog. We talked about the fact that you can get neurological symptoms, right? Or it can help reactivate other infections like in tick-borne with chronic insomnia. So in patient 1, the symptoms started 1 week before testing returned positive for COVID-19. And in patient 2, there was a sudden onset of fevers, cough, shortness of breath, loss of sense of smell, and diarrhea, but the testing was unavailable initially in the emergency room. In patient 1, after several months of treatment with antibiotics, during 2011 to 2012, the patient was in relatively good health until 8 years later when I saw him. But in January of this year, he started complaining of symptoms relapsing with moderate fatigue, insomnia, migratory joint pain, which many of you know is the hallmark symptom of active tick-borne in the muscles and joints. He also had pain in the back, shoulders, ankles, and feet. He had some mild tremors, which could be Lyme, but also the mercury toxicity, and mild cognitive dysfunction. His Lyme testing was negative. He had a negative PCR for Borrelia burgdorferi, negative babesia testing, although I'll show you later that I think he may have reactivated babesia based on the night sweats, and negative testing for other tick-borne co-infections. His complement levels were slightly elevated, and he had an increased immune complex detection by C1q binding. What was really of importance was that his rheumatoid factor, an inflammatory marker, was very high at 154, and his ANA initially was 1 to 640 and came down to 1 to 320, but all other autoimmune markers were negative. He had an elevated mercury level in the blood and a very minor elevated level of lead, which was 1, but by the way, you shouldn't have any lead in your body at all. It's still abnormal. Uric acid was slightly increased at 7.4, but he had a normal hemoglobin A1C, and we said earlier, hemoglobin A1C is an important marker for oxidative stress and inflammation. His CBC and biochem profile were normal. His immunoglobulin levels and subclasses were normal. Mineral levels were normal. So he presented with lack of smell and taste, metallic taste in his mouth, which probably was from the mercury, low-grade fevers, sweats day and night, sometimes interfered with sleep, body aches with flu-like symptoms, low back pain, a dry cough with labored breathing, scratchy throat, severe headaches, brain fog, and diarrhea. And as I said, symptoms started a week prior when his testing was negative. His hydroxychloroquine, at the time when we were looking at this, we were considering whether we would put him on Plaquenil and Zithromax and Alinea, because at the time when we were treating patients, we were looking at the study by Didier Raoult from France. It looked promising. Some of the studies were coming out on remdesivir. It was only lowering the illness by 4 days, or monoclonal antibodies. Protease inhibitors, lopinavir, ritonavir with ribavirin and interferon were starting to be discussed, as was melatonin or antibody-rich plasma. So we need to follow, and this is very important, by the way, in people get that COVID pneumonia. You can't just assume that it's the virus. Up to 25% or higher may get mycoplasma infections with COVID-19. You want to check the ratio of CRP to procalcitonin. A high procalcitonin would imply that they may have a bacterial pneumonia, predictive of, for example, mycoplasma, or you want to use doxycycline along with your antivirals. There's also been cases of influenza A, other viruses, which have been associated with COVID-19. This might be one of those people that you might need to put on Tamiflu, on an antiviral, apart from what you're using for COVID. So in patient 1, we gave him Plaquenil as a loading dose. We gave it to him for 8 days. We did decide to give him Alinea, nitazoxanide, which had been published earlier, effective for coronaviruses with MERS, and it seemed like there was some efficacy for COVID-19. We gave him Zithromax. We knew that he had no QT prolongation on EKG, so we didn't worry about the macrolide prolonging the QT interval. He tried albuterol for his shortness of breath, which did not help. And we gave him zinc, 40 to 50 milligrams a day. Initially, 1,000 milligrams of vitamin C 3 times a day was increased to 2 grams 3 times a day. 500 milligrams of 3,6-beta-glucan to support his natural killer cells. 1,000 of curcumin twice a day. 100 milligrams of sulforaphane glucosinolate, which is the broccoli seed extract, twice a day. N-acetylcysteine, 600 twice a day, which went up to 1,200. Alpha-lipoic acid, 600 twice a day. And we gave him glutathione at a 2,000 milligram dose all at once. And he was also on probiotics on the antibiotics, right? And you can see the dosing here of what we did for him. And now, of course, we're using higher doses of glutathione the minute we notice that someone has symptoms of COVID with shortness of breath. You can use up to 6 grams of glutathione a day safely in patients. And this is what I would use for people that have severe COVID pneumonia or ARDS. So what happened? Normally, you start peaking around day 10, 11 with COVID. So 4 days into the antibiotic regimen with Plaquenil, Zithromax, nitazoxanide, he started to improve. He still complained of anosmia and dysgeusia, poor appetite, cough, shortness of breath, very bad fatigue, and still had a lot of diarrhea with dehydration, but his pulse oximetries were remaining fine at 95% or higher. So we gave him a trial of 2 grams of oral glutathione for the shortness of breath, and he let me know that it significantly improved his shortness of breath within 1 hour of taking the glutathione. We then called a home nursing service, and we wanted to get him IV fluids because he was dehydrated from the significant night sweats and the diarrhea, where he was having difficulty keeping down fluids. A dose of IV glutathione was given over 15 to 20 minutes in 0.9% normal saline, and again, significantly lowered the shortness of breath and improved his sense of well-being. The second patient is a 48-year-old G4P4 female, 15-pack-year smoking history of Lyme and associated tick-borne infections. On March 22nd, she woke up with a high fever of 103 degrees Fahrenheit, very severe shortness of breath at rest that worsened with exertion, dry cough and chest tightness, which we're seeing in most of our patients with COVID and COVID pneumonia, nausea, dizziness, there's the diarrhea again, severe fatigue, body pains, shallow breathing, and again, she lost her sense of smell. She went to the emergency room, they did a chest x-ray, and they said, you know, it looks like a left lower lobe pneumonia, a typical was told of suspected 2019 novel coronavirus infection and atypical pneumonia, and they gave her 500 milligrams of azithromycin. Monday, March 23rd, she started a loading dose of hydroxychloroquine, followed by maintenance doses of Plaquenil for the next 8 or 9 days. With Zithromax, again, there was no history of QT prolongation. At the time, and this is before I was involved in the case, the doctor who was treating her gave her some Augmentin, amoxicillin clavulanate, because her shortness of breath was not getting better. March 23rd to 30th, the cough and dyspnea at rest was worsening with exertion, and her diarrhea persisted, just like in patient 1. This particular medical student who I had been training with Lyme for the last several years called me up and said, Dr. H, I need to treat this patient. What do you think I should do? I said, why don't you give her 2 grams of glutathione? And fortunately, they had glutathione at home. He gave her 2 grams of reduced L-glutathione with Alka-Seltzer Gold, in other words, sodium bicarbonate, alpha-lipoic acid, 600 milligrams, and 600 milligrams of N-acetylcysteine. The patient saw immediate improvement, described as being able to breathe better and have more energy within an hour of use, repeat dosing of 2 grams the next morning, as she was finally able to get out of bed, ambulate, perform her activities of daily living without feeling like she was going to pass out. She did try a lower dose of glutathione, 500 milligrams. It was not as efficacious. So take-home message, if you're going to do this for COVID, use the higher dose glutathione at 2,000 milligrams all at once, and it can be, as I said, 2 to 3 times per day. So what does glutathione do? What is it doing here with immune antioxidant activity? Well, as we talked about, glutathione can increase your innate and adaptive immunity. And I don't think most people are aware that it confers protection against microbial, viral, and even parasitic infections. Glutathione will increase the functional activity of natural killer cells and T cells. And you can see in all of these slides, we could have given CME credit for this. It's all in reports in the peer-reviewed medical literature. Glutathione is primarily intracellular, except in the lung tissue. There, it neutralizes reactive oxygen species. It acts as a mucolytic, just like N-acetylcysteine, and it combines with nitric oxide to make nitrosoglucosamine, are an endogenous bronchodilator. And I will tell you, I have asthma, and as long as I avoid histamine foods, my asthma is better. But I've been on higher dose glutathione at 500 milligrams twice a day for the last several years. My asthma is absolutely better because glutathione will act as an endogenous bronchodilator, much more effective than things like Ventolin, albuterol that they're trying in a lot of these patients. IV N-acetylcysteine has previously been shown that it may treat ARDS, and the only government-sponsored trial right now, by the way, with COVID is N-acetylcysteine. No one right now is doing a trial of IV glutathione in patients in the hospitals. If you have any way of convincing people in the UK or in other countries who listen to this to do a trial of IV glutathione in the hospitals for ARDS and pneumonia, that needs to be done, urgently needs to be done. And that is that first, excuse me, the second article that I just published. Glutathione has antiviral effects. It's been published previously against HIV, herpes virus 1, influenza A, murine leukemia virus, dengue virus, and hepatitis C. And the binding of the SARS-CoV-2 spike protein to the ACE2 receptors, as we talked about, which is the protein it uses to attach to the cell, depends on a disulfide bond formation. And that's exactly what NAC and glutathione are doing, is they form disulfide bonds with the cells or with the viruses. So one of the principal roles of glutathione in the extracellular fluid of the lung is to break these disulfide bonds, possibly slowing the rate at which the virus gets into our cells, and again, hopefully helping to reduce the peak viral load. And these are some of the studies on the antiviral activity of glutathione. I may as well just take this down. We're now from Amsterdam back to my house. Testing for COVID-19. Let's talk about antibody testing, antigen PCR testing, which is all available as of May 10th of this year. So antibody testing, can you trust the results? A team of scientists looked at 14 antibody tests. A few worked as advertised, most did not. So the testing we have for antibodies is IgA, IgM, IgG. Usually takes 1 to 3 weeks to develop antibodies. There are point of care, rapid immunological testing chips, IgM, IgG, whole blood, serum or plasma. PCR, there's a novel coronavirus real-time reverse transcriptase, PCR. And of course, that requires a nasopharyngeal and deep nasopharyngeal swab. The rapid tests are not vetted by the FDA. There's false positives and false negatives. If you look at what the companies are saying for IgG antibody testing, it looks like the sensitivity and specificity is great. But in the real world, and this was reported by CNN and the Washington Post just a few weeks ago, in the real world, it missed over 48% of the cases. The FDA in the United States just recently cleared the first home saliva test. This was a test kit developed by Rutgers University. And they submitted data showing that saliva samples collected by patients themselves under the observation of a healthcare provider was as accurate as deep nasal swabs. And then they approved a 15-minute antigen test called the Sofia 2 SARS Antigen FIA by Quidel Corporation, which is a nasal swab that produces results in 15 minutes. You can do it by placing it in a machine or developed on a countertop, but it is less reliable than the PCR. So in all of these tests, positive results are highly accurate, but a negative result does not rule out the presence of the virus. And you do need an antibody, antigen, and PCR for a full evaluation. So in this study that we just published in Medical Hypothesis, which was just, the edits were just published yesterday online, 3 novel prevention, diagnostic, and treatment options for COVID-19, urgently necessitating controlled randomized trial. One of the things we talked about in this study, and you should read it, is about using diagnostic apps and questionnaires for COVID, because you could collect the symptoms online via a questionnaire or a digital app. Do you have early symptoms of loss of sense of smell or taste, fever, sore throat, cough, chest tightness, shortness of breath, diarrhea, right? Central nervous system symptoms. And there was an app that was recently developed by Israeli researchers that they're now using in Canada. So you can do online tracking of vital signs, temperature, oxygen saturation, viral pulse ox, scored questionnaires that are statistically validated. But again, you would need a randomized controlled trial. But this is a way to monitor people from home without worrying about clogging up all the beds in the hospitals and exposing people. Okay, what about prevention for COVID-19? We're going to discuss social distancing, masks, hand washing, gargling, ionizers, need to avoid infected stool, glutathione and precursors, NRF2 activation, and a lot of these different nutritional supplements we've been talking about, plus pulsed ivermectin. So May 14th, some countries started to ease up the restrictions. Others were reimposing lockdowns amid a resurgence of infections. So here, at least in the United States, your country needs you to stay at home. So what are the prevention practices? Physical distancing, hand washing, isolation. And how important actually are masks? Well, what this study showed is that speech droplets can be emitted at a rate of thousands per second, and it takes 8 to 14 minutes in the air to dissipate. And you may want to consider using ionizer. I personally bought myself a personal air ionizer through Hammacher Schlemmer. It's about $150. It puts 36 million ions in a 3-foot radius around me, so that if any respiratory droplets or dust particles get close, it should take it out of the air. And again, of course, this would need to be clinically validated, but this could be a very clever way of using ionizers. And when we start seeing patients in our medical office, we have ionizers for our rooms. Cloth masks, even though they're not as effective as N95 masks, they may still prevent transmission. Here are some, however, non-recommended masks. The cowboy, the beanie-turned exterminator, the clown, the super high-waisted Spanx, the Birdman, the Lord of the Rings freak, the jokester, the spa, and of course, the safe doctor. Okay, what about gargling with something like Listerine? There was a study that showed that the throat and salivary glands are extremely important sites of virus replication. So we do need actually a controlled study, and we don't have it at this point, that it could be that by gargling, a couple of times a day, it might be able to help decrease the viral load in the body. What about the role for air disinfection and UV lights? Well, there may be a potential role, right? Using air disinfection to help get some of these people to slow down the spreading of the virus. What about reverse transcriptase PCR? You can get positive PCRs in the stool, negative in the respiratory tracts. So it's possible, and we don't know at this point, whether there may be indirect transmission. Initially, we thought that Plaquenil may give some protection against COVID. In this study, it did not protect those lupus patients who were already on it. Yet, there was a study that then came out in India where Plaquenil may provide protection in healthcare workers where they had a reduction in risk by 80% with 6 prophylactic doses, 400 milligrams one a week. But again, the sample size was not huge, and they did describe some ventricular arrhythmias. Then they did a study that was in the New England Journal of Medicine that was no benefit to Plaquenil in a controlled clinical trial. And this was the first large controlled clinical trial of hydroxychloroquine from the University of Minnesota and Canada that did not show any effect in preventing COVID in over 800 subjects given the drug, but there were no serious side effects. And by the way, for someone like myself, who's a Lyme doctor, who's been giving Plaquenil and Zithromax to people for decades, we have not seen serious side effects either. So what we discussed in the study that we just published, let's take a look at ivermectin. Right now, there are no validated protocols except for physical distancing, hand washing, and isolation. Ivermectin, chloroquine, and hydroxychloroquine have antiviral properties, but chloroquine and Plaquenil had recently been reported to have potential side effects. Plaquenil is determined to be ineffective. And even though the study was retracted from the Lancet, there's enough studies now, I think, that are showing that it probably is not the best prevention practice that we can do. Let's take a look at ivermectin. Ivermectin is an FDA-approved drug for parasitic infection. The World Health Organization considers it an essential medication. It's been shown to inhibit COVID-19 in vitro, where one dose had a 5,000-fold reduction of the virus in 48 hours in cell cultures. So this is the drug also where they showed the FDA drug ivermectin inhibits replication of SARS-CoV-19 in vitro. They then did a study on ivermectin in patients on respirators to decrease mortality. Now, this was a non-randomized, non-controlled study. It was an observational study from 169 hospitals across Asia, Europe, Africa, North and South America, almost 2,000 critically ill, hospitalized patients with COVID-19 who were ventilated, and 1,600 survived hospitalization, right? 361 died, 18.3%. The 52 patients who received a high dose of ivermectin, and this is one time, at 150 micrograms per kilo, these are the people who survived. The survival benefit for ivermectin was 18.6% versus 7.7% if they did not receive ivermectin. There then was another small group of people who took ivermectin and doxy. There was 60 people with COVID-19 with respiratory problems. All patients were cured within 4 days. No side effects were reported, and viral testing was negative post-treatment. Again, this is a small group of people that needs to be done in a much larger trial. So, and again, the study that we just published, 3 novel prevention, diagnostic, and treatment options. What if we were to try opening up the countries and the economy by doing a prevention trial of once or twice a week ivermectin? Ivermectin is normally given at 0.2 milligrams per kilo. This could be done with zinc, vitamin C, vitamin D, 3,6-beta-glucan, which again helps with your natural killer cells, NRF2 activators like curcumin and broccoli seed extract, and then things that block NF-kappa B like NAC, alpha-lipoic acid, and glutathione. We therefore would be giving people something with antiviral activity have anti-inflammatory therapies on board, but we do need a randomized controlled trial. The vaccine trials, there's now a lot of vaccines that are out there, and this actually was just published in the New York Times this morning. There's in preclinical, there's 125 plus vaccines that are not yet in human trial. And Texas A&M, for example, was looking at a tuberculosis vaccine with BCG, right? And I received BCG when I was in Europe doing my training in medical school in Belgium. They did not show any immune benefits, according to an Israeli study. And right now in the US, they've got a task force that's got 14 different vaccines that they're honing in on. And of course, the people have asked the questions, what about mutations? Now, it doesn't look like the virus is having a lot of fast mutations, which is good, but we don't know over time. Because will post-infection immunity also confer resistance? We just don't know. And I'll show you why. So in one of the trials that was done a while ago by Moderna, 8 patients, increased levels of neutralizing antibodies were found. But again, 8 patients is not exactly a big scientific study. This is a study from China, CanSino's vaccine, their COVID vaccine, showed promise in an early study in 108 patients. This was a adenovirus type 5 vectored vaccine. Now, the problem with this is the extent of protection is unclear because only 50% of those who received the medium dose developed neutralizing antibodies, and the adenovirus 5 vector failed in an HIV trial years ago. So they're looking at all these different technologies, messenger RNA vaccines, recombinant subunit vaccines, recombinant viral vectors, inactivated viruses. There's so many out there, and we just really don't know at this point which is going to be superior. But here's a risk of vaccines you're probably not going to hear about a lot, and it's endotoxins. So normally, the horseshoe crab blood is needed to check for endotoxins in vaccines. This has been going on for a long time. There's an alternative test called recombinant factor C that needs more study, but the European Pharmacopoeia has recently approved the alternative test, which means in Europe, in the UK, and in other European countries, they may start using this alternative test instead of the horseshoe crab blood to check for endotoxins. Now, the problem with this is it's unproven. We don't know how well this is going to actually check for endotoxins in the vaccine. And endotoxins can cause toxic shock syndrome with fever and death. So let's look at other ways again of what we need to do for prevention. Let's talk about for a moment stress management. Many people have fear during this pandemic. Well, fear lowers your immune response to viruses. We have doctors dying on the front lines. We don't have enough personal protective equipment. There's a lot of nursing home deaths and respiratory deaths, job insecurity, stress among farmers who need to kill their animals because they can't bring them to market. There's more domestic violence. In Russia, Russian doctors are falling ill. Some are from suicides that they've actually killed themselves. So we really need regular stress reduction practices during this time, whether it's meditation, yoga, Tai Chi, something that's going to help with the stress that is now happening as we deal with this tremendous pandemic, because stress will affect your immune function's ability to fight viruses. And now let's finish up the talk on potential treatments for COVID-19. Please take a look at this slide carefully. I think it pretty much encapsulates some of the feelings that people are now having. Is now the time I should panic? Am I too worried? Am I not worried enough? Right? Should I stock up on coffee and ziti and all kinds of things at home? I think a lot of people are feeling this way. All right, so the first thing we need to do is self-care. You always need to pay attention to diet, exercise, and sleep. So I'd like for those of you who are doing a good job with this, you can print off this slide, write in your name, good job, only ate most of the snacks in your house today. You do not eat all the snacks. Give yourself a high five on that one, because as you know, a lot of people are snacking inappropriately as they're staying home during this pandemic. So diet, exercise, and sleep, very important. The next is pay attention to mental illness, because if you have patients that have a history of mental illness, this may lead to much more severe depression, anxiety, and eventually suicide. All right, so let's go back again and look at the potential pharmaceuticals that we have for COVID-19. Plaquenil, Zithromax, chloroquine, zinc, I'm about to talk to you about. Alinea, The one I'm going to be focusing on is ivermectin and doxycycline. Remdesivir only helped by lowering the length of illness by 4 days, and the liver functions went up. Lopinavir and ritonavir with ribavirin interferon beta, they're looking at it. Very expensive drugs. Not everyone's going to be able to afford it. Melatonin, I think this is quite interesting. I'll show you the studies on melatonin and inflammasomes, and antibody-rich plasma of recovered COVID-19 patients. What they showed is in mice treated with COVID antibodies from a covered patient lowered the viral load by 2,500 times. So that, of course, looks promising. But there was a study of patients treated with COVID antibodies, and there was no statistical benefit. And this was just published in JAMA in June of 2020, but it was underpowered. So again, we're not sure at this point. Didier Raoult from France, May 14th, he had treated 2,600 patients with hydroxychloroquine and Zithromax. Mortality rates were less than 0.5%. They did a survey in France. More than 50% of doctors were using Zithromax and Plaquenil. But of course, you need to check the G6-phosphate dehydrogenase enzyme before using Plaquenil, and check the QT if you're going to be giving it with Zithromax. As of May 28th, he had almost 4,000 patients, and the mortality rate was less than 1%. But New York State did a study, 1,438 patients using Plaquenil and Zithromax, did not show any benefit. In British Medical Journal, 4 French tertiary centers used hydroxychloroquine, no benefit to using 600 milligrams a day prior to admission. The BMJ then did another study, and hydroxychloroquine in mild to moderate COVID-19, no help, and sometimes people had increased gastrointestinal symptoms. And then there was the retracted Lancet study where they said that giving Plaquenil or with Zithromax or chloroquine and Zithromax increased mortality. So this is being retracted at this point, so we need to throw out that study. An interesting link for me, when you're talking about increased mortality and morbidity, how do you not evaluate QT intervals or potassium or magnesium deficiency with arrhythmias? I would never think of giving these drugs to people without checking these things. What they did also show is that ACE inhibitors, not ARBs, and statins decreased mortality, at least in women, right, in these studies. And again, we know that statins also lower inflammation. So the Lancet and the New England Journal Plaquenil study was retracted. The trials were now resumed by the WHO. So this is the study I was telling you about earlier, that if you add zinc to Plaquenil and Zithromax, it looks like, at least in this small study, it lowered intensive care unit admissions, ventilation, mortality. Again, we're going to need a much larger randomized trial to see if zinc, in fact, is the kicker that helps these people to get better. Now let's talk for a second about NLRP3 mediated inflammation with something called inflammasomes. And we know that this dampened NLRP3 mediated inflammation happens in bats, which we think, of course, is one of the vectors of how we got COVID-19. So decreasing inflammasome activation, the role of melatonin. So just as I was talking to you about needing to block NF-kappa B, activating NRF2 and the antioxidant response elements genes, inflammasomes are another part of our innate immune system that sends pathogens and danger-associated molecular patterns called DAMPs. When you activate these inflammasomes, it increases these pro-inflammatory cytokines like interleukin-1 beta and IL-18 that we talked about earlier. High-level activation of NLRP3 inflammasome is needed for cytokine storms and lung injury. And what is the simple way to lower that? Melatonin. And as we talked about, as you get older, what are the 2 things that'll lower? Melatonin and glutathione. Now, wouldn't it be interesting that all we had to do was give people 0.5 or a milligram of melatonin at night with some glutathione and NAC, and we'd stop the morbidity and mortality worldwide? Please, someone who's listening to this presentation, do it, because I've been contacting the CDC and the FDA and the NIH and my state government and the governor's office and all the people I know. I can't get anyone interested in doing this randomized controlled trial, and it really needs to be done in the nursing homes. And you'll see that in the study that we just published yesterday, because the nursing home population is, of course, one of the most vulnerable. So the benefits of melatonin: anti-inflammatory, antioxidative, immune-enhancing features. They also found that low vitamin D may increase the risk of COVID-19 and severity. Vitamin D is needed for innate immunity. It boosts immune function against viral diseases, and it has an immune modulating effect, lowering inflammation. 3 Asian hospitals found that the risk of having low vitamin D increased the risk 8-fold of contracting severe COVID-19 disease. And then this study just came out about vitamin K and COVID. Say cheese, please. And initially it was a Dutch study, so of course they wanted everybody to eat Gouda. But I put on the slide, you can eat Stilton and cheddar from the UK because they also have some of these same properties with vitamin K2. And it looks like vitamin K, of course, it's involved in blood clotting. And in Japan, where they eat a lot of natto, they now know, and that's that goopy thing you see at the bottom of the slide, they now know this is very high in vitamin K. And they've shown in Japan, and these people who are reading this, very low rates of COVID-19 and getting sick. So again, this may be because they're not getting those severe inflammatory responses with clotting, right, which is inflammation in the blood vessels. They're looking at network-based drug repurposing, like taking drugs that have already been around, using it for COVID-19. If you look at that, they're looking at drugs like Paxil, which is for depression and anxiety, paroxetine. They're looking at irbesartan, which is an ARB for blood pressure, and there's melatonin, right? They're even looking at disulfiram. Now, disulfiram, of course, is the newest drug for Lyme, which hitting some of these persistent forms of Borrelia. No one's done a controlled trial at this point, but they have looked at it. The latest one that just came out is just take a bunch of Pepcid, famotidine. They had 1,620 patients with COVID-19. It was a retrospective study. And they found that the 21% who took famotidine, 60 to 240 milligrams per day, decreased the risk of intubation or death. So, you know, what do we need to do when we've listened to this talk? Everybody might want to consider taking Pepcid, melatonin, and glutathione with NAC. Of course, I'm half joking, but I'm half serious at the same point in time. Fortunately, I think melatonin and NAC, alpha lipoic acid, the rest is probably safer than even taking a H2 blocker like Pepcid. But of course, taking Pepcid for a couple of months is certainly not going to hurt. There was no help, by the way, with proton pump inhibitors. They've looked at natural protease inhibitors, like, interestingly enough, Curcumin, which we talked about was an NRF2 activator. Curcumin has an effect, just like quercetin and oleopurine, right, olive leaf extract. These look like they may have an effect on lowering protease, right, one of these enzymes that the virus needs to replicate. So, what are our potential enhanced treatments for COVID-19? COVID-19 induced inflammation and cytokine storm syndrome with macrophage activation syndrome has resulted in extreme morbidity and mortality. What they have found, and this was in the second study that I published, deficiency in red blood cell, serum, and in the lungs, alveolar glutathione, has been published in the medical literature for ARDS as well as viral bacterial pneumonias, resulting from increased levels of free radical oxidative stress. So in the published study that we just went online yesterday, high mortality rates from sepsis-induced disseminated intravascular coagulation due to COVID-19 has been associated with thrombosis and elevated levels of D-dimer. Now, when we published this study and we submitted it, it was about doing a randomized controlled trial of heparin. This is way before it was actually done by Mount Sinai, New York, showing that anticoagulation does help. But what I talk about in this article is also considering, for the people that are on vents, using diamoxacetylzolamide, which is a carbonic anhydrase inhibitor and pushes oxygen off of your oxygen hemoglobin to increase oxygenation in the blood. When I was in Tibet 10 years ago at 15,500 feet, I took acetylzolamide 500 milligrams twice a day, right? So I wasn't short of breath. There's also studies on sildenafil. Most of you know about sildenafil and for males as they get older. Well, sildenafil also helps breathing efficiency because as you give acetylzolamide, it's more difficult on respirators for your respiratory muscles, but sildenafil has been shown to help breathing efficiency. So again, this is a study that needs to be done in people on respirators, apart from using IV glutathione and some of the things we've talked about. In the autopsy findings, in people who died, they did find venous thromboembolism, right? This was just published on May 6th. where autopsy revealed deep venous thrombosis in 58%, in whom venous thromboembolism was not suspected before death. So again, you've got to be doing D-dimers and CRP and LDH levels and high sensitivity CRP, checking for cytopenias like lymphocytopenia, ferritin levels. All those markers we talked about earlier, very important to see who's going to be at risk and who needs anticoagulation. And then let's talk about some non-recommended treatments. Clorox chewables, Trump recommended, don't die, maybe. And non-recommended sports solutions. In South Korea, they had a very clever solution. In the absence of stadium fans, a South Korean soccer team used sex dolls and put them in the stadium. And by the way, I couldn't make this stuff up if I tried, okay? Thank you, Korea, for providing a source of humor during this time. By the way, they've stopped doing this ever since this got reported in the New York Times. Conclusion. We got it done in 90 minutes. Best practice guidelines. COVID-19 can cause cytokine storm syndrome and macrophage activation syndrome in susceptible individuals with thrombosis. Inflammation, inflammasomes, and NF-kappa B activation all increase chemokines and cytokines. These cytokines and glutathione depletion have been associated with ARDS and injury to the internal organs. Using targeted antivirals like ivermectin with or without doxy if you have a high procalcitonin, with antioxidant therapies like N-acetylcysteine, 600 twice a day baseline going up to 1200 twice a day if you get COVID. Alpha lipoic acid, 600 milligrams going up to 600 twice a day with COVID. Glutathione, 250 to 500 twice a day without COVID preventatively, but 2000 milligrams of glutathione, preferably liposomal, but L-glutathione also works at least twice a day, up to 3 times a day with COVID pneumonia or ARDS. With ARDS, IV would certainly be preferable. 1000 milligrams of curcumin twice a day or higher. Sulforaphane glucosinolate, 100 milligrams twice a day, broccoli seed extract. 0.5 to 1 milligram of melatonin at bedtime. 40 to 50 milligrams of zinc. Vitamin C, 1000 milligrams 3 times per day, going up to 2 grams 3 times per day with COVID pneumonia. Vitamin D, making sure you're on at least 5,000 IUs. The one I would use would be K2D3 because they did show that vitamin K has cardioprotective benefits. And then using 3,6-beta-glucan, 500 milligrams once a day, which helps increase and support natural killer cells and T cell. Published case studies show glutathione rapidly helps dyspnea. By the way, we've had other patients now have also improved rapidly with glutathione, as had James Brusacy, who is the medical student who helped publish that first study we did on glutathione with COVID-19 pneumonia. And randomized controlled trials, of course, need to be done, but they need to be done as soon as possible because I may have discovered a solution for this pandemic and I can't seem to find anybody who's interested in doing a controlled trial. And that is beyond frustrating, folks, to sit on something where you feel like you have an easy solution and everyone's looking at drugs which are expensive and which not everyone is going to be able to afford. And the vaccines, even if they work, to put out a vaccine that quickly without proper safety studies is dangerous. Conclusion. In patients with significant risk factors, age over 60, diabetes, cancer, immunosuppressant, pneumonia, acute respiratory distress with dyspnea, blood in the phlegm, cytopenias, low counts, high ferritin over 500, high LDH levels, high sensitivity CRP above 41, D-dimers. If you've got any high levels of these with risk factors, you want to go up to higher doses of N-acetylcysteine, higher doses of glutathione, because this has antiviral, antioxidant, mucolytic, and bronchodilatory effects, along with the supplements zinc, vitamin C and D, alpha lipoic acid, curcumin, sulforaphane, beta-glucan, and melatonin. And as we said, high CRP procalcitonin implies pneumonia, bacterial pneumonia. Add doxycycline on to ivermectin. So, finishing up, check D-dimers, LDH, cytopenias, high sensitivity CRP and ferritin, rule out macrophage activation syndrome. Check a chest x-ray in someone who's got shortness of breath, look for that ground glass opacities, and do home pulse oxes. Less than 90% in a home pulse oximetry, high risk. Check CBC and biochem profiles, as well as INRs, PT, PTT for liver, kidney involvement. Follow troponin levels and CPK for cardiac involvement. Consider non-invasive ventilation versus getting them on a ventilator. Consider heparin with IV vitamin C, maybe calcium channel blockers. Consider using acetazolamide sildenafil. Definitely, I would consider using high-dose glutathione with IV N-acetylcysteine, possibly nebulized glutathione in some populations, which has been shown to help with asthma as a bronchodilator. And again, ivermectin and doxycycline is my choice at this point for treating people with COVID pneumonia. When my wife and I go on vacation next week, I will be taking along ivermectin and starting to pulse ivermectin along with all the supplements I told you about. My final slide, wisdom is the marriage of knowledge and experience bound by compassion. So thank you for listening to the talk. And now we will open it up to questions.
Thank you so much, Dr. Horowitz. That was absolutely extraordinary, really stunning information that I think we can all use, whether we're doctors, therapists, or patients. So I'll just begin by asking a few questions that we received before you started from forums, and just mentioning that we will stick to questions relating to COVID-19 today, even though some questions have come in relating specifically to Lyme, but maybe we'll be able to go into those another time. And also, I won't ask the very long questions. Some have come in from clearly scientists who are perhaps writing articles as well and submitting them. So maybe we'll send those to you to answer specifically. So first of all, and again, some of these you may already have covered, but I'll just repeat, because obviously if the questions are there, then the answers are needed. Are Lyme patients with co-infections more vulnerable to a serious outcome from COVID-19, would you say, particularly as may be the case for patients in the UK, as they've often had little or no treatment?
I'm sorry, could you repeat that? I wasn't sure I got that.
Are Lyme patients with co-infections more vulnerable to a serious outcome from COVID-19, would you say?
I have not seen it. Now, the Lyme patients that would be more vulnerable would be the ones that are immunosuppressed. They have low IgG levels, which happens in up to 20% of patients with Lyme. We published that back in 2018, 2019. Those who have subclass deficiencies like subclasses 1 and 3, specifically subclass 2, which you need for like pneumococcal pneumonia, patients with low natural killer cells or natural killer cell function. So, you know, we do immunoglobulin levels, subclass levels. We do check natural killer cells and CD4, CD8 counts. So you need to know how your immune system's functioning, and you want to know your vitamin D levels and zinc levels and everything else that we talked about. But I have not seen Lyme patients be more susceptible. So right now, I don't think, unless they're immunosuppressed, I don't think they're at higher risk.
Okay. One question came in from someone who's wondering whether a very low CD57 of, for example, 5 would translate into being more at risk, or is CD57 similar to the different types of immune markers that you've just mentioned, or is it in a class of its own?
Well, so CD57 has been discussed as a marker for Lyme. I don't personally use it as a marker for active Lyme because it's not specific enough to diagnose it. It can be affected by mercury toxicity, by autoimmune disease. So I don't use it specifically. So I can't really comment so much on it. But I don't think it's going to probably be the biggest factor, because in the people who have low DC57, and we've seen it with people with active Lyme, again, we're finding that that is not going to be the biggest factor. It's probably your antioxidant status, how much glutathione you have, whether you have low glutathione, low vitamin D, low melatonin. I think those are going to be probably the factors based on the literature that I just showed you. That will probably be the biggest factors that will make a difference.
Okay, thank you. And relating to MCAS, that's mast cell activation syndrome, if patients are really severely affected living in a mask prior to COVID-19, do you feel that basically everything that you've just talked about will be the kinds of approaches they should take as well? Even though
absolutely. I mean, the thing about mast cell activation is it's a tremendous cytokine storm in a lot of these people, but primarily through histamine. So, you know, you're tracking histamine, chromogranin A, tryptase, prostaglandin G2. These patients do need to be careful because they already are very inflammatory in nature. So in those patients, if you're in a moldy environment that is, because mast cell activation is stimulated by Lyme, mast cell activation can also be stimulated by mold. So if you're not in a safe environment, you may need to get out of that environment because you don't want to be driving inflammation. But there are ways of helping to use things like chromalin sodium, things like DAO, diamine oxidase, thing that lowers histamine levels, using antihistamines, using H1, H2 blockers like Zyrtec, cetirizine with famotidine, for example, to block histamine. We do that all the time for people who have mast cell. And there are treatments. In fact, there's a broad range of treatments. Neil Nathan actually just lectured with me the weekend before on this. So if people want to learn about mast cell and want to learn about vagal retraining, which you need for this, I would probably suggest speaking and reading Neil Nathan's book, which is an excellent book on it.
The Toxic, the new book that's just come out.
That's exactly right.
Yeah, yeah. And one listener here asks, zinc recommendations vary online. You mentioned 40 to 50 milligrams, I think, a day. Since some want to be on zinc for many months at a time, is there a differentiation in that dosage that you would recommend, or basically stay on it until this crisis is over?
I personally would stay on it. I mean, normally, and this from nutritionally, you have to watch the zinc copper ratios. If you take too much zinc, it lowers copper. You need copper for superoxide dismutase, which handles free radical stress. You certainly, if you're going to be on this for a long time, you could always check copper levels to make sure you're not throwing it off. But the thing about zinc is when we looked at zinc levels, we published this in the journal Healthcare back in 2018, I think it was about 18% of our patients were zinc deficient, both in serum and red blood cell zinc. So a large percentage of the patients who come to see me are zinc deficient. And that would not bode well because, as I showed you with macrophage activation syndrome, zinc also regulates how the macrophages secrete cytokines. So, you can always check zinc levels. I mean, I'm taking 50 milligrams of zinc a day. Eventually, when I do my next set of bloods, I'll certainly consider checking zinc and copper. If you want to play it on the safe side, just check your zinc copper ratios. That's an easy way to do it while you're checking vitamin D ratios and some of these other things that we've talked about. And by the way, you can check glutathione levels in the blood. So if you're unsure about your glutathione status, go and check it, right? Labs in the US check this all the time.
Right, thank you. Another listener asks, is there evidence already that this virus could accentuate ME/CFS-like symptoms once you've had it? In other words, could there be an ongoing onslaught of chronic illness from this afterwards?
Absolutely. I don't think there's any doubt, but what we don't know at this point, in one of the Chinese studies, the people were antibody positive, PCR positive. They followed them with symptoms. Their symptoms improved. Their PCRs turned negative. They kept them indoors another 2 to 4 weeks. And then he said, all right, you've got no symptoms. You're PCR negative ×2. Go to work. They went to work and 13 to 14% reactivated the virus. Now, what does that mean? We don't know. We don't know whether that means you're going to transmit it to other people as an asymptomatic carrier, or as I said, you're an asymptomatic carrier in the stool because they're finding that this reverse transcriptase PCR is showing up in the stool. We just don't know. But any viral infection, like normally with CFS, myalgic encephalomyelitis, we know that viruses like herpes virus 6, you get exposed, or EBV, you certainly can get an increase in CFS ME symptoms. I would not at all be surprised if the same was COVID, but again, you're going to need the studies long term. We don't have them, but I would not at all be surprised knowing on what I've seen with HHV6 and EBV that you're going to probably see the same thing. And what you need to watch for in those patients is mitochondrial dysfunction, because once you get so much free radical oxidative stress, the mitochondria are not protected. And there's certainly a certain group of people with CFS ME who have mitochondrial dysfunction, just like a third of the Lyme patients have it. That was published by Garth Nicholson years ago. In those patients, you may need to be looking at not only antivirals, but looking at things like NT factors, glycosylated phospholipids, high-dose CoQ10, acetyl L-carnitine, D-ribose, using NADH, right? Things that are going to help your mitochondria to regenerate. That would probably be the group I would look at, apart from doing the 16-point MSIDS map, because when these patients come in and we run the 16 points, we usually find that there's multiple things on the MSIDS map that is driving inflammation. zinc deficiency, problems with the microbiome. They're not sleeping at night, which is increasing interleukin-6. They've got Lyme, they've got co-infections, right? They've got heavy metals and environmental toxins driving environmental stress with reactive oxygen. And then they've got downstream effects from the inflammation, like their hypothalamic pituitary dysfunction. The men end up with low T, low adrenal function, mitochondrial dysfunction, POTS dysautonomia. So inflammation and the downstream effects of the inflammation, whether you're calling the infection COVID or whether you're calling it Lyme and co-infections, it's really the same model, right? Because free radical oxidative stress, you got to lower it down. It's the same thing with Lyme and it's the same thing with COVID, right? The difference in Lyme is, and by the way, in Lyme, they even found some coagulation defects early on in some of the studies that were published. It's just nobody's giving heparin to people, you know, with Lyme. I mean, there were some practitioners early on. I've never done it. But I think it's important at this point to realize that infections, inflammation, and immune dysfunction, the three I's that I talked about, whether the infection's Lyme or it's COVID, the same inflammation, the same immune dysfunction is seen with NF-kappa B and NRF2 and all of the biochemical pathways that we discussed.
And can all cause hypercoagulation, fibrin buildup, and so on.
It was shown in Lyme early on, and it's being shown in COVID.
Yeah, thank you. Another question here. What to do to inhibit NF-kappa B in individuals who don't appear to tolerate sulfur compounds like NAC, ALA, and glutathione?
Well, so I would have to know really what intolerance is. I mean, again, for the people that can tolerate whey-based protein, WHEY, whey-based proteins are a way that you can get cysteine molecules in your body, right? So you can drive your own glutathione production using it nutritionally. But I would have to find out what that means of don't tolerate, because most people tolerate alpha lipoic acid. The only intolerance I've seen is high dose where you can get reactive hypoglycemia. And the only people I've not seen tolerate glutathione are ones with chemical sensitivity who can take IV glutathione. But even those patients with chemical sensitivity, they usually can tolerate low dose oral glutathione simply because glutathione is part of your phase 2 liver pathways that you use, right, for inflammation and detoxification. So, you know, God gave us all glutathione. So you're not giving somebody something that's exogenous to their body, right? So I think those people are probably the chemically sensitive ones or people with hypoglycemia. Those are the only ones I've seen have a problem tolerating it.
Okay, thank you. You touched on this when you talked about testing, but the question has come, which is always very interesting. What percentage of people with COVID appear not to develop antibodies? Have you got any sort of statistics on that yet?
You know, I don't know at this point. In fact, I just did a consult this morning for someone who is IgM positive, but IgG negative, PCR negative. And I don't know what to make of a positive IgM with no IgG. Now, we see that in Lyme all the time. Lyme affects B cell production. It was initially shown in Nicole Baumgart's work in mice at Stanford, and we showed it. We published it back in 2018, that Lyme patients will get 45% will get IgM CDC positive Western blots, but never make IgG. It's possible that in the tick-borne population, they're only going to make IgM and not IgG. That's something that's going to have to be followed, you know, later on, but we see that in Lyme all the time. But I don't think anybody knows exactly. We don't have enough of those, you know, patients who are asymptomatic, who develop the antibodies. We know they're supposed to be 80 to 85% of the people get exposed and are asymptomatic. But I think, you know, time's going to tell. We just need a lot more information and studies done.
Yes, yes. Another question here. If a person has active Lyme disease and co-infections plus heavy metals, and they're taking glutathione for COVID-19, would you suggest that they also take binders with the glutathione?
So, you know, it really depends with the heavy metals, because a lot of these heavy metals are bound to the tissues in the body. They don't stay in the bloodstream very long. So right now, I mean, I'm only using binders like charcoal clay or compounded cholestyramine in people that have mold toxins, whether it's aflatoxins, trichothecenes, gliotoxins, right? I mean, we're using binders for those. I'm not using as much binders for metals unless the levels are really, really high. And in those cases, then I might consider DMSA, dimercaptosuccinic acid, or DMPS or something else, or EDTA if they had lead. But those levels have to be really high to use those type of drugs. My patient, for example, that I showed you who had high levels of mercury, it was just because he was eating too much fish, right? So, you know, later on, you might want to do a 6-hour urine DMSA challenge to see how much is in the tissues, check hair analysis, recheck the blood. But I'm not using a lot of binders right now, except in the people that have mold toxins, or I'm also using like phosphatidylcholine.
Okay, thank you. What are your thoughts on nattokinase for hypercoagulation?
I don't think there's enough study at this point. I know there's a lot of integrative doctors that use it. It may be that it's actually quite good, just like there's studies on using other enzymes in between meals. They've showed that enzymes in between meals, like serrapeptidase and some of the others, also have an anticoagulant effect, but you would need a randomized controlled trial to really see what it does for COVID. But it certainly is a study worth doing.
Thank you. And a few other questions relating to other antivirals like L-lysine. Do you think that that's something that could be added in?
It's mostly for herpes viruses. I have no idea what it would possibly do for COVID, for an RNA virus like COVID.
Okay, thank you. Quite a few questions relating to binders here that came in later. Have you heard about humic acid's effect on stopping an RNA virus of this kind? Would you consider that worth trialing?
Yeah, I know of it, but I've not seen any published studies on it. If there are published studies and somebody wants to send it to me, I'm happy to read them, but I haven't seen anything on it specifically.
Okay. And then an article last week in one of the big British newspapers said that smokers are recovering better from COVID-19, evidenced from data from China. Is that something that you've heard?
That patients,
strange one is smokers recover better from COVID. That's nothing I've heard yet. But
that makes no sense whatsoever.
It doesn't, does it really?
Because that's a lot of free radical oxidative stress on your lungs. Already we're exposed to 10,000 free radical hits. I forgot the number, if it's per second or per minute, living on the planet. And smokers, it's like billions that you're exposed to, and that would use up your glutathione and your antioxidants. So I'm not quite sure how that one would actually happen.
It sounds a bit like the Lancet study. Possibly
I would retract that
a little
one.
Bit of a fake. Yes. Many are asking whether we can have the slides, as the presentation was so concentrated with excellent information. And you did kindly say at the beginning that you would allow us to have the PDF to distribute.
Yeah, I will make PDFs available. And of course, we're going to make this talk available online. And please, everyone who's listening, please share this with as many people as you can, because I suspect what I've talked to you about today is going to save lives. I mean, again, without randomized controlled trials, we can't be sure. But if you just look at the basic science that I showed you today and some of the early preliminary work, boy, it sure looks good. At least that's what I'm doing, because I'm going on vacation next week, and everything I showed you today is what I'm taking so I don't die. We'll see how it goes. But any contacts at the high governmental agencies, please show these slides and show this presentation right to your NHS and to people who might be able to do a study, especially in your nursing homes.
Brilliant. Thank you very, very much. We'll put a link to those plus to your articles with the recording, which we'll make sure goes up as quickly as possible. Quite a few of the questions haven't been asked yet, so we'll collect those for perhaps next time when we're lucky enough to have you again in a month or 6 weeks' time. More information will be in by then. Just to say a huge, huge thank you again. This was an absolutely stunning presentation, so much information. I'm sure a lot of us will be watching this many times.
Yeah, this is, as I said to you, I've been reading 1 to 2 hours of literature per day. And this is pretty much, I'll tell you, this is an up-to-date review of what's going on. So if you want to really do it without having spent a gazillion hours, just watch the slide presentation and listen a few times and you'll get it. As I said, I think at this point, whoever has the contacts, please just see what you can do with randomized trials, because the things I've discussed today should be safe. I've used a lot of ivermectin. I've never seen problems with using it even daily in people. I'm suggesting these protocols because they are the safest and what I think will probably be the most efficacious based on an extensive scientific literature review. So please, my blessings to everybody. Stay safe. Please follow the prevention practices we talked about today. And hopefully this information will benefit you and benefit others, but share it as widely as you can. Superb.
Thank you so much for giving us so much. Just a quick mention that we'll have Dr. Armin Schwarzbach next week in our COVID series, part 2 of his discussion of SARS-CoV-2 testing. So he'll be updating us on the situation in Germany and what his tests have shown so far. And that's on the 17th of June at 7. And we'll have Dr. Sarah Myhill on the 25th of June, following up on questions relating to ME and COVID from her superb presentation that she gave a few weeks ago. So we'll be sending out information about that. But thank you so much again, Dr. Horowitz.
It's my
Absolutely tremendous, and wishing you a wonderful holiday next week.
Thank you.
Thank you very much, everyone, as well, for listening. And the recording will be up in the next few days. Thank you.
Okay.
Bye-bye.
Bye-bye.
Bye.